Hello students, welcome to this session where we will discuss about in detail regarding the management of third nerve palsy including its diagnosis. So, the main learning objectives under this is what is the cause and the muscles supplied by the third cranial nerve or its oculomotor nerve. What are the etiology and characteristic clinical features of a total third nerve palsy, and how do we diagnose and make a line of management for these people. You must be now well known about the anatomy of cranial nerves. You should have finished your anatomy classes so far earlier, but just to recapitulate, you know that the third nerve is the oculomotor nerve, that see the trunk is quite thicker than the other two ocular nerves, namely the trochlear and the abducent nerve. Why it is? Because it supplies almost all the structures in the eye. Mainly we will just talk about that later on. And the nucleus lies in the floor of the aqueduct of Sylvius, is characteristically in nearby with other neurological structures, and then after it comes to the orbital portion, it divides into a superior and an inferior division. A superior division goes to a superior rectus and the LPS muscle supplying it, and the inferior division to the inferior rectus, inferior oblique and the medial rectus muscle. So, you see, and there is a group of fibers which go to the ciliary muscle and the sphincter pupillae. So, you see, on the whole you have 6 or 7 groups of muscles, both intraocular and extraocular, supplied by the oculomotor or commonly termed as a third cranial nerve. That is the importance of a third nerve to the eye. So, what are the muscles, exact muscles when it is paralytic give rise to? Let us see what exactly each one give rise to. When LPS goes or becomes paralytic, it causes a ptosis, that is drooping of the upper lid, covering the almost invariably total pupillary area, or sometimes even a total palsy. This you can say as a subtotal. If it is not covering the pupil completely, you can say it's a partial. When it covers the whole fissure, it is called a total ptosis. The next is elevation deficiency in abduction, that will be caused by the involvement of the superior rectus. Then the next is there is a depression deficiency in abduction caused by the weakness of the inferior rectus. Then there is a right inferior oblique, there is elevation deficiency in adduction. Then there is adduction deficiency because of the right medial rectus weakness. So, almost all directions except the lateral rectus and the superior oblique, you have the limitation of movements when third nerve is affected by any cause. So, that is about extraocular muscles. What about the intraocular muscles? It also supplies the ciliary muscle and also the sphincter pupillae. So, it causes, when that gets affected, it causes a mydriasis and also accommodation weakness. Mydriasis alone will be a rare feature to see, but sometimes in case of aberrant regenerations, where while the muscle is recovering from its weakness, or when it is associated with the parasympathetic fibers involvement, like in Horner's syndrome, the pupil may be constricted. So, now we come to the major portions where the sites of palsy occurs. That is, one at the level of nucleus, one at the level of infranuclear, then comes fascicular, whether it is a nerve trunk, whether it is a partial, a superior division or inferior division. We will just deal with one by one. What is it? Nuclear third cranial nerve palsy. This can be distinguished only by its associated neurological signs and some clinical findings. In complete involvement, you need to rely on the associated neurological signs, but incomplete findings, it involving the subnuclei, you may not have enough neurological signs, but the clinical features will be ptosis, if present, will be bilateral depending upon the extent of its involvement. Mydriasis and cycloplegia also, if present, will be bilateral. Why is it so? Because the fibers to LPS and the fibers to the pupil and the ciliary muscle are subserved by one single nucleus. And then the next finding is a contralateral superior rectus paresis, or it is seen as a bilateral superior rectus paresis. Why it is bilateral? It is said the superior rectus fibers, the contralateral fibers, especially the axons, before it becomes into a nerve fiber, just crosses the ipsilateral form. So, both fibers, both the axons get affected in case of nuclear involvement. So, now we come to the infranuclear part. This could be intracranial mainly, which is affecting, as we told you, LPS, superior rectus, inferior oblique and medial rectus, and the ciliary muscles and pupil. That is intracranial complete nerve trunk. It could again be involving only the superior or only the inferior or the individual muscles. This we will deal it in separately. So, now what is it? Mostly under congenital we have birth trauma, or children, sometimes very early children may have inflammations, meningitis, meningoencephalitis or neoplasms, or sometimes even ophthalmoplegic migraine can cause in children. This should be read as a children. In children can cause all these problems. But what about acquired? Acquired, usually the common reason what you see in adults is a posterior communicating artery aneurysm. You see how many arteries are related to the third nerve. This is a third nerve, and this is an artery, this is an artery, and this is an artery, and you have all these junctions of 3. And these vascular aneurysms anywhere in these 3 arteries or at the base, it can cause a compressive pathology. Do note, it is very different. It is a compressive pathology on the nerve. So, this also, the tumors anywhere here also can cause a compressive pathology. So, this direct damage from the adjacent tumors could be anywhere from the base of the skull or pituitary or cavernous sinus. And usually this important here is the pupillary fibers also will get involved. The next common ones come vascular insufficiency. What we say is a microvascular insufficiency, that is diabetes mellitus or hypertension. These are the common things. But here usually you have a pupillary sparing, maybe because the nerve trunks are okay. It's only the problem is only in the vessel supplying the nerve. So, you do not have a pupillary involvement here. And the other common you see is a closed head trauma or any inflammations of any intracranial pathologies, or a migraine also can cause a total third nerve palsy. And again 2 syndromes have been described under this in association with the brain stem structures. That is, one is called a Weber's syndrome, where you have ipsilateral third nerve with contralateral hemiparesis. It is mainly because damage to the third nerve and cerebral peduncle together. And the second one described is a Benedict syndrome, where there is again ipsilateral third nerve, contralateral hemiparesis, but also associated with ataxia and intention tremor. That is the differentiating point here. This is again associated damage to the cerebral peduncle and red nucleus along with the third nerve damage. So, what are the clinical features of third nerve now? So, whatever we said earlier, depicted earlier, that all these muscles what they affect, all those motility defects are seen along with ptosis in complete third nerve palsies. And usually because all these muscles are involved, it results in exotropia. Usually there is no vertical deviation because both inferior recti and superior rectus are equally involved in there. So, you do not see a vertical deviation. Sometimes rarely you may see a small hypo, but that will not be very significant. And because of this we have described under evaluation why there is a crossed or uncrossed diplopia, but herein you have a crossed diplopia because all the other movements are affected and the patient has got a gaze, normal gaze only on the lateral gaze. The double vision will be there in all quadrants except in the lateral version. So, when there is a full ptosis, though they have exotropia and then crossed diplopia on examination, they may not have in a compensatory head posture because ptosis is there. So, there is no necessity for them to keep the head compensated to get a binocular field. Whatever is there, they were closing, that eye is not being used. So, because of all these things, next thing you get a muscle sequelae. We know what is muscle sequelae and then what are the things to look for. And the next good or important finding is aberrant regeneration. This also quite common while getting third nerve getting regenerated. And then status of pupil, whether it is smaller, whether it is dilated, accommodation weakness, that is all the things can be there in as a clinical feature. So, come to the ocular movements here. You say this is depiction of a right third nerve palsy. A right third nerve palsy, there is a right exotropia. See a large angle on fixing, so that gives the movement restriction on all these sides, levo version. There is no adduction possible, there is no elevation possible, there is no depression possible. But at the same time you also see the muscle sequelae in the other eye. Muscle sequelae, you have all this muscle sequelae when you have in the other eyes, you have this. So, you need to, whenever you have third nerve total palsy here, invariably you should look for the muscle sequelae as we described under evaluation under strabismus. What is this? The muscle sequelae, as you are seeing, you should also look for the primary and secondary deviations. Earlier we have said this is a total third nerve palsy right side. Okay. So, patient is now fixing with the normal eye. You see a deviation. This is called a primary deviation. And now patient is, as you see here, she is not able to bring the eye into a primary position, still is in abducted position, but trying to fix with that eye. So, in that case there is total involvement. So, you have a very large exotropia, that is a secondary angle of deviation. This is very important for us to know to plan for the management. And as we said, diplopia, sometimes you may not see diplopia because of the ptosis, it is always crossed, and maybe you can see maximum separation in adducted medial rectus position, but also you can see a small vertical separation in up and down gazes. So, that is also depending upon the equality or inequality of a vertical recti muscle involvement. This is a small video showing you the findings in a right third nerve palsy. As you see here, the right eye is ptosis, you see the twitchings of the eye, and then the right eye is exotropic. And let us see how the movements are. See, we have elevated the right ptotic eye, see the left exotropia on fixing right eye, so large, elevation is deficient, depression is deficient. At the same time, you just note the overactions in the other eye, normal eye. See how the muscle, almost the eyeball is disappearing into the lid. Depression is affected. So, these are the typical clinical features of a third cranial nerve, both in the affected eye and in the normal eye. We won't say normal eye, it is an unaffected eye. So, what is this aberrant regeneration we were talking about? Earlier we have talked about this, maybe in evaluation also. This is just a few points here. Why mainly it occurs? You may not be surprised to know the third nerve, as we said, it supplies 7 groups of muscles. So, whenever it is transected and then tries to regenerate, it is possible one group of the muscles getting misfired into another group. That is why it is very common in a third nerve palsy. So, this you can have superior rectus fibers getting connected to the medial rectus, or inferior rectus fibers getting connected to the LPS, causing upper lid retraction on looking down, or LPS fibers to the muscles of mastication. So, all those things are common to see. So, this is usually said to be present both in congenital and acquired, but it is common in acquired mainly in lesions of trauma and in cases of aneurysms or space occupying lesions, but it is less common with our microvascular pathology. See, you see whenever look at the lid movements, see the eye movements on either way. The lid gets ptotic one eye, retracted one eye, elevates in other places. So, the action is not a good, not a normal way. This middle aged lady has recovered from a total third nerve palsy, still with the partial restrictions. So, you have the partial ptosis there, and then movements slightly recovered. See, you can see some elevation is possible. It is not like the other girl where the elevation is so possible, and also see the left eye, the muscle sequelae, also it is not so great as you saw with the previous patient, it is much less. That means the spread of comitants or the recovery is getting slowly and partially, and also you can see some amount of an aberrant regeneration also in her. See, on fixing with the right eye, fixing the left eye, deviation is so small. You can also see a small hypotropia in right eye. That is maybe an unequal regeneration of superior and inferior recti. See, on looking up there is a lid retraction, and on looking down also the lid retraction. This is the aberrant regeneration what we were explaining to you earlier. And herein you see a child with a congenital third nerve palsy on left side. So, ptosis is there. On ptosis, see the jaw, on moving the jaw to the side, see the change in the left eye. There is not much change in the left eye, but when she moves the jaw to the other side, see the lid gets, the other eye becomes ptotic and this eye becomes little bit elevated. So, these are the causes because of there is a misconnection between the third nerve fibers and fifth nerve fibers. What we say is a jaw winking phenomenon. These findings why should we know is management of third nerve palsy itself is difficult because it involves almost all the muscles except 2, and here with that associated the subarachnoid regeneration makes the plan for management little bit difficult. That is the important. And what about the pupil? As I said earlier, the pupillary involvement is usually common in communicating artery aneurysms, resulting in dilated and accommodative lost pupil. So, rarely in congenital third nerve palsy also you can have a pupillary involvement, but it is very rare. And Pupil-Sparing, this is very important to know because it is a very common condition. Repeatedly we are telling a pupillary sparing in vascular lesions. There is some importance, we will come to it at the end. And this is the lady which you showed, this is a partial nerve. There is some amount of depression is possible, some amount of elevation is possible. So, showing there is a partial recovery of it. So, how do we evaluate these people? Apart from a routine history, you give importance to ophthalmic, medical, neurological history as we explained under evaluation of strabismus. And under strabismus evaluation, I have explained what are the things to look for. And the special note is here, fundus should be checked for presence of optic atrophy for any compressive lesions or a papilledema for space occupying lesion where you can have increased intracranial pressure. In non-traumatic third cranial nerve palsies involving the pupil, always you assume the cause should be aneurysm and then start evaluating to confirm the diagnosis or to rule out the diagnosis. The next, once you do this, next we need to confirm whether there are other ocular nerves involved or not in third nerve because it has got a close relationship with the other nerves. So, how do we know it? We will just talk about the fourth nerve little later. About the fifth nerve, it is easy for you to see because corneal sensation you can check it. If that is reduced, tells us there is a fifth nerve involvement, and that can be there in cavernous sinus involvements, and rule out the sixth nerve by checking the saccades. As you check the abduction, if there is good saccades of the movement possible, that shows it as a normal lateral rectus. And always think about whether the possibility of myasthenia and then do test to rule out that. And one more thing, this what is this central fusion disruption, especially in case of closed head trauma causing this third nerve palsy, you can also have this central fusion disruption. We have talked about it in the initial explanations under esotropia. What is this is central fusion happening. If that center also is damaged, even if you are going to make the eye aligned at the center, thinking that you are going to give a diplopia free field, they may not be able to fuse the images from both sides if the cortex is not functioning. That is called central fusion disruption. If that is there, you can discuss with the patient that it may not be possible for us to do anything on the double vision. So, how do we distinguish the involvement of fourth nerve palsy? As you see here, ask the patient to abduct, and then after abduction ask them to look down. That will show us the intorsion. See, you just ask the patient, just look carefully, it will intort. So, that is the sign of, you can have some identity as any vessel noted in the limbus, and then ask the patient to, because you cannot check for the direct depression in down gaze, that is the main action of superior oblique. That is not possible because adduction is totally lost. So, this is the way, only way, checking the torsion you can find out whether the fourth nerve is intact or not. See, you can see very well as the abducts and then comes down, the eye nicely intact. So, what are the other investigations that you should do? Apart from ophthalmic, general and neurological investigations, whatever we have done earlier, that should be done in these cases, especially whenever we suspect aneurysms and space occupying lesions. And neuroimaging, when should we order the neuroimaging? Whenever you see an isolated oculomotor nerve palsy with features of involvement of brainstem, or there are multiple cranial nerve palsies associated fourth or sixth nerve, or if there is any proptosis or conjunctival congestions. Third nerve palsy associated with field defects or a papilledema, or if the third nerve palsy is not at all resolving in 3 months time, or X-ray showing an enlarged pituitary fossa, or a pupillary involvement with meningeal signs or aberrant regenerations. All this time you should ask for a neuroimaging study should be done to rule out the possibility of a space occupying lesions or any other pathology. So, what is it? The course of this disease? The course will be here, normally we expect that to be recovered, but in third nerve palsy recovery, total recovery is very unlikely. It could be partial or subtotal. Total recovery sometimes, especially in cases of microvascular ischemic cases, where you expect in 3 months to 6 months time, usually they recover completely if that treatment is done properly. And other congenital, other causes, recovery is very low, and during follow up you may have this point you have to see. Then the follow up should be at least every month, 4 to 6 weekly, at least for 6 months you should give them time for the improvement. And during that, all these things, as we discussed under evaluation of paralytic strabismus, will help us in assessing the improvement or status, whether they are going down or improving. So, what will you do when we are waiting for the recovery? If the patient has no symptoms, is okay, but what should be done? In children, this should be done, occlusion should be done to prevent, because usually the eye is always out, very easily they can go for amblyopia. At least to some extent by occluding you can prevent or improve at least some part of the vision in those patients. Also to prevent the contractures of the lateral rectus, that is also very important. In adults, supposing a partial ptosis recovered 1 month later, they are coming with a double vision with a slight pupillary exposure, then you have to think about an alternate eye occlusion. What will you do? Will you do the same like in children? No. Here little bit different way. Alternate eye means when they are at home they can use the peritic eye, because it has all the false pointings and difficulties in moving around. So, when they are indoors they can use the peritic eye, but when they go out they can use the normal eye. So, your occlusion advice should be accordingly. And if that is nothing is possible, they have eye straight, ptosis is the only problem, you can always use the scratch glasses. And surgical management again is going to be difficult. It is not like managing in either one possibility, there are so many other problems. So, mainly our aim should be to give a diplopia free field either in primary position or in down gaze. We do not bother about giving binocular vision in the up gaze. So, then you have to consider what are the available muscles to keep that alignment possible. So, that they have to assess. So, what are the points we have to note before we go in for surgery? Significance of the ptosis. Is it small or subtotal or total? Or there is ocular movements, whether the vertical movements have recovered or horizontal movements have recovered. What are there any contractures by checking FDT, FGT and the saccades and aberrant regeneration. These are all the things is like a check for a surgical assessment. So, when you have a partial recovery, how will be it evident? There will be some adduction possible. So, you check for the possibility of adduction, whether the patient is able to move the eye to the primary position or even further in a adducted position. So, that should be done. and then you also check for the FGT for enough force generation. In that case, if we have both these two, then you can think about strengthening the medial rectus with the supramaximal recession of the lateral rectus. As you see here, a peritic eye, this is a peritic eye, and there is with the partial recovery, patient is able to bring the eye to the primary position. That means the medial rectus is to certain extent acting. So, strengthening this muscle and weakening this muscle to the maximum will help this patient to attain a primary position. So, that should be our surgical choice. So, the other alternative here is when there is no medial rectal tone is good, or the transposition has to be thought of. That means the vertical recti transferred to the medial rectus, provided the tone of the vertical recti muscle should be good. This is the vertical recti tone should be good. Medial recti is not exotropic, not adducting properly. This tone is to the vertical recti must be good. So, you transfer the superior rectus and the inferior rectus to the medial rectus. So, the medial rectus tone will get better. So, it will adduct much better, the results will be much good. Then the next comes here again, as a muscle sequelae, the superior oblique will overact. So, its normal action is a depression. So, in its overaction there will be more hypotropia. So, what we can do is you can disinsert the superior oblique muscle. Some surgeons even they shorten it and then bring that superior oblique muscle to the insertion of the medial rectus muscle. So, this tone will come here along with a recession of the lateral rectus. So, what does the superior oblique do? This tendon is used to elevate and adduct the eye, so that the eye can get aligned in primary position. This may not be very successful procedure, but when there is no other option, this could be a better choice. So, what is it when there is no recovery at all? The eye is in exotropic position, no movements, adduction, elevation, depression, everything is absent. So, then what will be do? What will be doing? Two things can you do. One, you anchor the globe mechanically to the medial periosteal wall, or you recess the lateral rectus completely, anchor it to the medial lateral wall, and then do a surgery on the medial rectus resection. So, these two options can give a little bit better prognosis, may not be always good, but if you are lucky you can have a good anchor. This is a globe fixation where see the eye totally out, no movement at all possible. This we have anchored this globe to the medial periosteal wall. That means you connect, you mechanically push the globe to the center, and then with the permanent suture you connect the insertion of the medial rectus to the periosteal wall. Or some people earlier first time when they did, it was to the medial palpebral ligament, but now they said periosteal wall will be much better anchoring area. So, then this is the surgical results, you can see straight position. When you come to the management of ptosis, you have to do it a careful planning, because after cutting the strabismus you might have some correction of the ptosis also. If that is not corrected, if the action of LPS is very good and there is enough Bell's phenomena to protect the eye, then we can think about doing a frontalis sling surgery to correct the ptosis. If that is not possible practically, then we can think about giving spectacles with the crutch, what we call this as a crutch glasses. You have a mechanical support so that it can lift the lids and then under the orbital margin. So, this can be given. Initially they may have some problem in wearing a mechanical pressure, but they will get used to it. There are many patients who like to wear this also. Students, now we have come to the end of this management of third nerve palsy, a complete third nerve palsy. The key point here is, you know all the etiology, but the key point here is, often we see this cause as a vascular pathology due to diabetes or hypertension or problems. So, when you have an isolated third nerve palsy, treat and look for and then treat for hypertension, diabetes. Do not stop with that, you have to follow up. When you follow up, along with that you have a pupillary involvement maybe a few days later, or you do see aberrant regeneration in a week or 2 weeks time, you have to order for the neuroimaging to rule out other pathologies where we might have missed it. Or whenever you have, there is no improvement at all, you have waited for 3 months, there is no sign of improvement of anything, maybe even if you have done one MRI scan earlier, there is no harm in repeating it once more to rule out any other pathologies. So, management of third nerve palsy is not that straightforward, but if it is appropriately planned and then done, you can achieve to certain extent a good alignment and also a good binocular field in the primary position and in down gaze. Students, hope you would have understood some basic management, etiology, how do we diagnose an isolated one and a combination of cranial nerve palsies, and then what are the basic steps we have to carefully undertake in managing these third nerve palsies. Good luck.